Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We're so happy that you chose to spend this time with us in these very serious days. Without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
Thank you, Dr. Barbara Neighbor-Stevens, and thanks to our co-moderators, Dr. Lawson and Ms. Romero and Ms. Hines, Dr. Hines. I think our esteemed Dr. Ivan Walks is traveling today and may not be with us, or he might. So starting off, we have a distinguished guest speaker today that we're going to discuss issues with. Dr. Chapman. Dr. Edwin Chapman is an expert in substance abuse disorder. And I got a letter that he was just asked to be the champion elected to the organization, to SAMHSA, that controls substance abuse. I'll ask him to explain that later, but he's a graduate of Howard University. He's extremely well known. He's a fellow of the American College of Physicians. He's a specialist in internal medicine, and we welcome him. But to start off with some news, I read that today that the Secretary of State of the United States declared the ambassador from South Africa to be persona non grata. And the reason he was decided to be that because they're calling him a racist. He happened to be black. He happened to have been evicted from the town where he was born because it was declared a white-only area. And he expressed the opinion that the United States MAGA movement is concerned because the population of the United States by 2050 is expected to be majority non-white. And so our president declared that he was a racist. Our Secretary of State decided he couldn't stay in the United States, so he's been, I presume, expelled. But this is the time that we're living in. We know that thousands of federal employees have been fired, laid off. We know that any reference to people who have served in the military, if they're black, if they're brown, if they're female or transgender, that they've been removed from any recognition. They've been removed. The history of the Civil War has been removed from the Arlington archives. So we're living in a very, very difficult time. And we believe that in many cases, some of this is going to account for an increased death rate, an increased decrease of the already unlevel playing field for the health of Black people. In that regard, we did request the expertise of Dr. Chapman to join us. Dr. Chapman, welcome to the Black Health Trust again. And we'd love to hear any statements you'd like to make, but we'd like to discuss some of these items with you and how this affects what you constantly talk to Congress about, talk to us about, of treating people with substance abuse disorder and how there's disparities in payment, eligibility, and all those things. Welcome, Dr. Chapman.
Thank you so much, Randall. It's a pleasure to be back. And we followed your lead ever since I was a medical student. You were on the forefront of issues like this back in the late 60s, early 70s at Howard University College of Medicine. So this is fighting these battles and having the background and the instruction that we had prepared us for this day. We've always recognized the fact that there are disparities in healthcare. And if you look at the book 1619 by Nicole Hannah-Jones, they mention the fact that post slavery, post emancipation, that there were statements that were made that the reason why we don't have universal health care now is because of the fact that uh, a sick slave is worthless. So you don't need white man's medicine. And if we wind that clock forward, we're now seeing this played out very clearly where medicine is being weaponized, is actually being weaponized to uh, 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 to treat certain people and not treat others.
Can I make a brief statement? Is this why they shoot race horses if they break a leg? I'm sorry.
You know, it's amazing that we're seeing this played out the way it is. Um, One of the initial concerns that I had, of course, was when Trump pulled out of the World Health Organization, and then he immediately removed or froze documents coming out of the CDC, NIDA, SAMHSA, et cetera. And all of this is orchestrated so that when uh, people are not able, certain people are not able to get health care, that we don't have the data to follow those information sets. And that's what we follow. That's how we really determine what what works and what doesn't work. And all of this is being orchestrated so that these many moves that he's making uh, cannot be tracked. Uh, the patients that I treat, as you know, are opioid addicted. And we've always been trained that everyone is a human being and everyone deserves health care, regardless of their stature in life. So the homeless, the addicted, the poor, urban, rural, everyone deserves health care as a right. And that's the premise that all of us operate from. And I think the fact that we're now seeing again uh, Trump putting in uh, so-called work requirements, certain restrictions on access to health care is all part of winding the clock back to that post-emancipation period. These are dangerous times.
Well, that's very, very, very interesting the way you look at that. So, just to start off the discussion, are there any specific moves that the current administration has done to decrease even further the funding that it requires for communities of color to get the care they need, especially those who suffer from substance abuse disorder?
So, most of our patients are covered either under Medicare or Medicaid or a
Mm.
combination of the two. So we've heard that in Project 2025, of course, Trump has denied that he is cutting money from Medicare or Medicaid. But we know that there's already been talk that they're looking at $880 billion to be removed from Medicaid services. And of course, uh, it's going to impact our community disproportionately. But in terms of pure numbers, uh, I'm sure that poor whites and whites in rural areas are going to be impacted even more so.
Mm.
So this is a this is just it's just unimaginable. The fact that um, the president is talking about bringing uh, businesses back to the United States. And this was a statement that our president-elect for the National Medical Association, Dr. Roger Mitchell, pointed out that you want a healthy workforce.
Mhm.
So bringing work back to the United States with an unhealthy workforce does not add up. Roger called it uh, a national security issue. And 7 years ago, when I first started giving talks on the opioid epidemic, I described it as a national security issue. And of course, we see that it impacts everybody. That recent studies showed that uh, uh, due to deaths and overdoses, 321,000, at least 321,000 children have been left in foster care between 2011 and 2021. So that just gives you an idea of how this impacts not just the person who may be using drugs, but it also impacts their family and the entire community.
No, thank you. Dr. Barbara Davis Stevens,
Yes, Dr. Maxon.
you have any comments or questions for Dr. Chapman?
Well, I was waiting for Dr. Chapman to not only talk about Medicaid and Medicare, which we really need to look at a little closer, but also we have, and it was, we have a system in this country of federally qualified health centers. And this safety net system was greatly enhanced under Obamacare so that there would be a safety net in place. The funding to that program as well is in danger, and it is the access point for care for many, many people, both in urban and rural communities. So when I think about what's going on, my take on the situation is that it's not an individualized approach to different programs. I think of it more like when you're out cutting weeds. We're not cutting one weed. We take a whole handful of weeds and just chop it with the knife. And that's what I see. I think that any aspect of our society is being impacted, and everyone in our country is being impacted. So it is a total attack and a total dissembling of everything that has been developed in this country, whether we're talking health or anything else. Going back to the question of Medicaid and the stealth-like way they're attempting to do the cuts, I work in Medicaid. Being a pediatrician, it's hard not to work in Medicaid because almost 50% of the children born in this country are born on the Medicaid program. But people, when you say Medicaid, they generally think Black, poor, and they may think children, and they may think pregnant women, or they may not. But the largest majority of Medicaid spending goes to nursing homes. And as this is a huge majority of the funding of Medicaid goes to nursing homes. And as this country ages, we don't have a real good system for taking care of the elderly, especially elderly that no longer have family or their own support system. And so nursing homes are a critical part of the services that are available to aged, frail individuals. So I think what is going on now, we're just at the beginning of it. People aren't really yet feeling the total impact, but when that punch comes, it's going to be a knockout.
Let's for a moment stop. And what exactly, for our audience, is Medicare? who's to take care of and what is Medicaid and who qualifies for that? Can you speak a minute on that, Dr. Chapman and Dr. Neighbor-Stevens?
Yes. So Medicare generally is for retirees, but also for people who are disabled. So you can get so-called SSI and qualify for Medicare. Medicaid is generally,
Social Security, right?
yes,
Okay, and that comes out of your paycheck.
that's correct. That means that you've been paying for that your entire life.
Right. So it's something that you have paid into that system that gets deducted every paycheck to a certain amount in that. And okay, so that's, go ahead.
And of course, Medicaid can be a supplement to Medicare, particularly for medications and co-insurance for services that are not covered under Part A or Part B. So the two combined could give one pretty much 100% coverage if you qualify.
So Part A Medicare is for hospital coverage.
Those are for hospital services.
Part B Medicare is for physician coverage.
That's correct.
Okay. And then we have Part C, which is Medicare Advantage.
Correct.
Okay, which is a large HMO type organization. That's Kaiser, Humana, and all those. They offer you a toaster when you sign up for it. And most people are being put in that if they don't know. Now, Medicaid itself, you have to be at a certain level of poverty for that. Is that correct?
That's right. And it varies from state to state. I think in the district, you have to be 150%. You can qualify at 150% of the poverty level, but it varies from state to state.
And what is that generally thought to be, the poverty level?
Again, I believe it varies from state to state. And that's why we have such disparities in terms of how Medicaid is accessed. As you know, there are at least 10 states now that did not expand Medicaid under Obamacare.
Okay. Well, thank you so much. And thank you, Dr. Neighbor-Stevens. Ms. Romero, you're on. Sam, is Ms. Romero muted? So it's just you and I, Dr. Neighbor-Stevens. Is Dr. Lawson on?
Not yet. Oh, he just popped on.
Hello, Dr. Lawson.
Hello.
Good. We're just having a discussion with Dr. Chapman, and we're speaking about how the new cuts and moves of the administration have denigrated the care for people with substance abuse disorder. And we have Medicaid being threatened, Medicare being threatened. And we went through the definitions of who's eligible for Medicare and Medicaid and how these might be impacted. As a psychiatrist, also working with Dr. Chapman in some areas, how do you see this affecting the fatality rate amongst our communities?
Well, I think one of the other issues that people tend to forget is that historically, mental health services have not gotten the same kind of degree of treatment. And the real issue arises if folks have both physical problems as well as mental health needs. Because this system is set up now so that if you have some states, if you have one or the other, you can't have both. And then in Texas, there's weird rules in terms of exactly what is a mental disorder, which is much more restricted than other states. And many of these problems existed previously, and up in the last decade or so, there have been significant inroads that were being made, especially with Obamacare and others, that have pushed the idea of making sure that mental health, substance abuse services get the same kind of coverage and support as physical disorders. And there was some attempt to try to change some of the rules in terms of people with comorbidity, but that's just beginning. The real problem is that the gains that have been recently made are being reversed, are not moving ahead. And it's just to remind folks, um, many of these kinds of problems uh, account for large percentage of our populations. Um, Mental disorders, for instance, one of the major causes of joblessness and job inactivity of any kind of physical disorder. And now they're talking about adding work requirements, um, which runs into real problems when you're talking about people who have mental disorders. And then on top of that, we're facing very real issues in terms of what's going to happen when we look at coverage for pharmaceutical products. Again, some of our newer treatments have occurred in the last couple of years. Or is there going to be an effort to pay for these treatments? Because they're new, some of these are going to be very, 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 very expensive. And I'm talking about treatments like sickle cell, Alzheimer's, and others. We're talking about millions of dollars. And also in cancer, some of the newer cancer drugs as well. And then there's talk of restricting some of the treatments for diabetes and weight loss and so on. So,
I want to delve into some of those, but let me go back to Dr. Our speaker for today and ask a question. And this is, we know that substance abuse disorder, I have a question about why it's made to criminalize it versus looking at it as a health issue. There was a story in the news earlier about Prince Harry, the so-called Duke of Suffolk, who has a big issue with our current president, that he was granted a visa to the United States, and he had admitted in a book that he had used drugs, and Trump and the Secretary of State want to potentially deport him or give him problems. And how is this use of drugs versus being treated as a health issue, Dr. Chapman, versus being treated as a criminal issue? How is this perceived and being handled as we go forward?
So, Randall, that's always been the issue in our community. The opioid epidemic was always treated as a criminal behavior. It didn't become a medical problem until about 7 years ago, and actually addiction medicine was not even recognized as a specialty until 7 years ago. But the aegis of all of this is because of the disproportionate impact of opioids over the past 30 years on the white community. Then it became a disease. But to get to your point, let me just give you a very clear example. Here in the District of Columbia, in 2023, there were 250 inmates in the DC Detention Center on buprenorphine and methadone for opioid treatment. In 2024, there were 400. Today, there are 500, which tells me that access to treatment in our community is still in the criminal justice system, in spite of the fact that many of these individuals, and these are young people, I've been in the DC jail, and most of them are males under the age of 40. And we've been getting some of them. And what happens is when they go to jail, they get treatment with buprenorphine or methadone, but when they're discharged, their Medicaid has been cut off. They obviously don't have a job coming out of jail, and many times they're homeless. So we've gotten a number of patients, and I've actually sent some redacted profiles of patients showing that this is a consistent pattern. And that means that it's a setup for recidivism. How are they gonna get their medication if they don't have insurance when they come out? So we've developed a system where we're able to temporarily medicate these individuals until their Medicaid is turned back on. We're able to write a prescription, send them to public health clinic, and hopefully wait for their Medicaid to get turned back on. But many of these individuals come out and are not able to navigate that system. So they relapse, they go back to the same behaviors that got them incarcerated in the first place and end up right back in the jail. So my theory is that's why we're seeing these numbers in the district increase. And I was at a conference at Howard. It was actually a book review, and there were some individuals there from Baltimore who said that the same pattern is occurring in Baltimore. So I'm pretty sure that what we're seeing is exactly the system that Trump is trying to set up, where it becomes very difficult for these people to get treatment outside, and the only way they can get treatment is in jail, but it's going to fill the jails up.
Yeah, let me just add that one of the advantages of being in the district is that they can get treatment in the jail. In many states, we'll go back to the Reagan administration. Reagan made the point that if people are incarcerated or in jail, why in the world should we have to why should we have to continue to provide Medicaid and Medicare to get in the jail, to get treatment in jail? And so a lot of states, including California, just stop paying Medicaid, Medicare while folks were incarcerated. The problem
Reagan, just say no.
well, just say nothing. And the problem is, well, some states like DC allowed to continue to get support for all in jail, but then they have to switch to standard Medicaid, Medicare when they leave jail, and that creates this gap. So in this area, at least, there is a gap, and it depends on whether or not you can get legal support, whether or not you can get, whether or not your social worker is very dynamic or not, where folks can get started again, or whether they can work the administrative hurdles to get started again. And many folks just don't have it together enough to be able to do it. I mean, they're coming out of incarceration. They have lost any kind of service support or connections to the community they had. So they're coming out fresh. And most of the systems around here do not provide that kind of transitional support when they come back in the community.
So this conversation really raises a very important point that I've been trying to make over and over again. Think about the CEO of a Medicare Advantage company or a Medicaid company. If I know that my patient can get treatment in jail, why should I aggressively go after these individuals on the outside and pay for it? So we've actually set up a dichotomous situation where it's to the advantage of these for-profit companies not to track these patients down, not to aggressively go after them, because if they go to jail, they can get treatment in jail, which switches the burden of cost onto the Department of Corrections. I had a meeting 2 weeks ago with the deputy director of the DC Detention Center and the medical director because of this very situation. So now their bill for buprenorphine has gone up. Now they have to screen patients for hepatitis and HIV that And if they find it in the jail, then they have to treat it. If they have diabetes or hypertension that wasn't treated on the outside, now all of that burden is switched to the jail. So you can see, and of course, most of these patients have some mental health problems as well. So all of that burden is now on the Department of Corrections, and now they're looking at their budget and trying to understand why they're getting stuck with the bill.
And what Chaplain did was really, really pretty significant, because I had a battle in Texas to try to get them to test people for substance abuse. They wouldn't do it. They simply would not do it. At least here, through Dr. Chapman's efforts, they're at least testing them to see if, in fact, there's a substance abuse problem. And let's not forget, when these folks leave corrections, we talk about the homeless problem. Who makes up the homeless? Half of them, mentally ill and substance abuse people. So while they're homeless because they can't get it together, or they're homeless because they're using drugs, they're homeless because they can't negotiate the administrative system to get them housing when they're struggling with substance abuse, mental health services, and don't have the resources to pay for those services.
Let me ask Dr. Barbara Naver-Stevens, one thing. For the past few weeks, we've been discussing the effects of nutrition and why in our community we have so much obesity and bad health from ultra-processed foods. I wonder if we could comment on why that contributes to health disparities in general. And I think that's related to overall problems that we have in our community. Care to comment on that, Dr. Naver-Stevens?
Let me make sure I understand the question. Is the question the impact of obesity on getting care?
No, the impact of not being able to afford healthy food in our communities of color. And that oftentimes leads to obesity and other health risks. And even we discovered some years ago that there's a gene abnormality on chromosome 22 that if there's a second hit, whether it be obesity, diabetes, lupus, HIV, it can trigger a high degree of renal failure. But all these things, the second hit, the stress of obesity, bad food can lead to bad health. I thought you might want to comment on some of that.
Well, when we have talked about obesity and the relationship between obesity and the access to healthy food, part of that is the question of access. And access is having the funds to afford it, as well as proximity to the source, to a source of healthy food. There is also a component to the obesity issue of the quality of even the healthy foods. What do I mean by the quality? There is a whole issue of when our fruits and vegetables are raised, they are contaminated by the soil that they are growing in, which then, when consumed, triggers reactions in the body that can lead to obesity. Obesity is such a complex subject. But what I would say is that when you do attempt to start fresh, and what do I mean by starting fresh? I mean, when you start with babies and young children, it is, you really come to understand that it's not just a question of quality food, because the babies are on very limited diets, and yet they still are, we have an increasing curve of infant and childhood obesity. So there's more to it than what we've been talking about. And it's a subject that if we don't get our arms around and get the appropriate interventions in place, we're not going to see an increase in the overall health of our community.
Thank you very much. Let me go back to Dr. Chapman and Dr. Lawson again. So I'm an 83-year-old Black man. Do I have less pain, or can I stand more pain than a non-Black person? If I have pain, is it real? Or do I need more or less of the same type of treatment, Dr. Chapman?
You need the same type of treatment as everybody else. Unfortunately, there's a perception that Blacks either tolerate pain better or don't have the same amount of pain as whites. Believe it or not, I mean that's a perception that has accounted for some of the issues related to patients receiving pain medications in the hospital or the doctor's office. So we know that the opioid epidemic, for example, in the African American community, is more related to street drugs, where people are self-medicating oppression, depression, anxiety, as opposed to pain. So a lot of our patients started on street drugs because of that. They didn't get their medication. They didn't get these medicines from the doctor's office or the hospital.
And I might add to that, we're not just talking about physical pain in terms of noxious stimulation. There's also a general belief that African Americans do not suffer as much psychological pain or distress. There's a strong belief in the military that African Americans don't get post-traumatic stress disorder as common, as frequently. And yet we find in our community and in the military that African Americans are more likely to suffer from post-traumatic stress disorder, but unfortunately are far less likely to get treated for it. So what do? There, as Dr. Chapman noted, folks go out and try to get street drugs or other non-prescribed medication to be able to try to deal with this. So it's a much larger issue, a general idea that African Americans, and related to from perception of slavery times, that African Americans somehow are impervious to the usual troubles and problems that we face in the world, such as noxious stimulation, psychological distress, hard work, struggling, all of that, sadness, all of those are assumed to be less common in African Americans, and we see that in less of access to psychotropic medication, pain medication, and as a result, folks have to go out and get the way any way they can, which often involves street agents.
Dr. Lawson, I have an admission to make to you. I'm what's called a dental chicken. I'm totally afraid of and have post-traumatic stress from going to the dentist. I can't stand thinking of the needle.
Mm.
So I appreciate what we've discussed today. Dr. Neighbor-Steven, any questions in the chat or any comments?
While she's looking, let me just make two other comments. You know, there's been a lot of focus on the fact that there's over the past 12 months, there's been about a 25% decrease in opioid overdose deaths. But we have to remember that that those decreases are primarily in white patients. We've invoked things like PDMPs, where the doctors have to check the registry to see if a patient is getting pain medications or opioid pain medications from other places. That has an impact on the white community, but obviously the PDMP has no impact on the Black community, where patients are getting their drugs from the street. So we've seen a dramatic shift, of course, in the street drug supply from agriculturally based heroin to synthetics. Here in the district, we're now at about 96% synthetics in the form of fentanyl and other additives. So we don't see heroin here in the district by and large. We only see these synthetics that are have now infiltrated not just the heroin supply, but also cocaine and illicit drugs as well.
So
Yeah,
Dr.
it was,
Chapman, Dr. Neighbor, anything in the chat so we don't ignore our audience?
No, not at this time.
Okay, go ahead.
one thing I was expecting to see in the chat, I'm surprised, is that the comment that our Kay said that the problem in the African American community, violence and so forth, is related to the use of psychotropic agents and that and the exposure to social media. And he has actually proposed restricting the use of psychotropic agents for African Americans who are depressed or have PTSD, and also suggested that we should take our youth out of our communities and put them in isolated areas where they're not exposed to social media and things like that.
I heard a comment by the president speaking at the Department of Justice that freedom of the press must be criminal. I do not understand that. And I know, Dr. Chapman, you've just been given a new position with SAMHSA. Can you clarify that and comment on what your new job is or new invitation is to be a physician champion?
Yeah, so basically that was a letter that I received today asking to participate in community education on substance abuse and mental health issues. So it's a voluntary role, but certainly an honor that I accept as a member of the National Medical Association and consider to be something that I certainly would want to share and certainly want to keep our members informed throughout the organization. I think what we're seeing now really elevates even more the importance of the National Medical Association, the Black Psychiatrists of America, independent thinking, because we're faced with this whole idea of anti-DEI, the fact that we're going through these machinations to get rid of science. There's an article today on Dr. Fauci, if you can believe, they removed a mural of Dr. Fauci from NIH. That's how serious this problem is. I mean, we're in an anti-science move.
So what did Mao Zedong do when he took over China? He burned books. What happened over there?
That's right. That's right.
And I think Alexander the Great might have done the same thing as burn the books in Arabia way back when. Keep the people ignorant and dumb. So let me ask you this. What is it that we as ordinary citizens can do to combat some of these issues that you see in front of us? What can we do?
What we're doing right now is to continue to tell the truth. The truth is, as they say, truth beaten to the ground will rise again. It's hard to deny the truth. We're seeing it every day. We're seeing it with the measles epidemic that's spreading across the country. Yet we have a new leader at NIH denying vaccines. We're going to have to continue to tell the truth and to continue to speak up and speak out.
What do you think
And
about?
I might add that it's not just, and there was a nice and several articles about why the Democrats lost in the recent elections. One of them is that um, while the intellectuals are well aware of what's going on and well educated in who they reached out to, many of our folks in systems, non-academic settings, and regular folks in the community uh, just aren't getting the appropriate information. So we can do a lot in terms of going on uh, going in terms of popular networks and national TV, the Washington Post, and so forth. But many of our folks do not get their information that way. You get it in the barbershop, you get it in the beauty parlor, we get it some in the churches. We need to go out where the people are and provide them with this kind of things like this show, which I just made sure that my church at least got the link uh, to make sure that our people in the various settings, folks are too busy trying to just make a living or survive to go out and looking in terms of running down to the library or looking up articles and so forth. Make sure that our folks get the information so that they can make educated decisions and also resist some of the um, uh, I would say not only misinformation, but um, self-promoting, this, as Dr. Chapman knows, destructive information that while maybe in the interest of large companies and the interest of the larger society, may not be in the interest of individual African Americans.
So let me ask one last question before I go back to Dr. Barbara Neighbor-Stevens. What is your opinions, both of you, Dr. Chapman and Dr. Lawson, of Dr. Oz coming into the federal government? What do you think about him as a professional and what he brings to the table or might not? Dr. Chapman?
Well, again, it's showtime as usual, and that's what Trump has been good at. Just what Dr. Lawson said. He's been good at spreading misinformation, using all of these different media platforms that we have not focused on. And so I think Dr. Lawson's point is very clear that we have to go directly to our communities and connect to people who in their various ways of communication.
Yeah, Howard University Hospital had Dr. Oz come by who encouraged people to get physical exams, which was good. But then right after that, came out with some unproven statements. And in fact, he's several of his articles have had to be withdrawn from publication. And he has been cited for providing misinformation in referee journals. So it's not just getting information out, but also recognizing that some of these folks are putting out misinformation that at least the scientific community has written critical articles about. Unfortunately, these kinds of criticisms don't get in the general public. What they hear about the initial statement, even though it could be completely bogus.
Dr. Maxey, we have a comment from YouTube. So we're very happy that our YouTube audience is with us as well. The comment is that older Black men are dying from opiates at a higher rate in Philadelphia. But what I want to do is really broaden that comment into a question and ask. We've been talking about drug use in younger people, but maybe could both of you comment on drug use in older members of our community?
Yeah, so there was a series published by an organization called 51st News in conjunction with the New York Times and the Baltimore Banner. There were about 11 national newspapers that showed, yes, that older Black men born between 1950 and 1970 are dying at a disproportionate rate. But that is the generation that survived heroin, crack cocaine. Now they're in their 60s and 70s. And I have one who was in one of those articles who just turned 80. So it's that generation, but there's a new generation that I described currently in the DC detention center that we need to focus on as well.
Yeah, and the other point to recognize is that many historically during the war on drugs, African Americans ended up getting disproportionately longer sentences. And many of those folks were finally getting them out of prison, out of jail. Some of these folks were dependent and do not have access to the usual treatment or services. So they end up getting back on again. But unfortunately, just don't have the community resources to be able to do anything about it. So it's not just a young people's thing. Um, the good news is that we're living longer. The good news, we're getting folks out of the correctional system. The bad news is that we got an elderly population that cannot get the information, access to treatment and support services just because they're too much later in life and never got started in the first place.
As we move to closing comments, let me ask Dr. Chapman first and then Dr. Lawson. This is a question I have with medical practice. I have a number of senior ladies somewhere between 65 and 85 years old, and they always want cough syrup, but they don't want regular cough syrup. They want cough syrup with codeine in it. And I said, but you don't have a cough. But I need my cough syrup. I need my cough syrup. What's going on with that? And what's the best way to handle it? They're sweet old ladies. They're not drug addicts, so to speak, as we think of them. They're grandmas, great grandmas, and nice people in general. How do we approach that? How do I approach that? Dr. Chapman?
Well, I tell you, what we've learned is that anybody can get addicted to these drugs, and there's a genetic component to it. We just have to address it from a medical standpoint.
I think the good news is that actually, at least in some of the genes, especially the alcohol, African Americans are less likely to become addicted and to develop habituation and so forth. The bad news is, again, this information problem. In the rural area where I am, morphine was routinely used to treat a whole host of problems. And the folks in the community, and some of the old-timey doctors out there said that, this is what we got to use because it's what we know. So we got to recognize that not everybody lives in an urban area next to a medical center. We need to go out and educate our folks, especially those who are not linked in to academic centers or who have the latest information at CME courses and so forth. We got to go and educate our fellow physicians. And this is something that I think the NMA has done a very good job in, and recognize that African American physicians historically has been left out of the academic literary information system. And I'll say that bluntly. And part of it's because we're just too busy to tie in, to keep up with what's the latest and what's going on, or get free CMEs coming into your office.
Thank you so much. Dr. Chapman, I have one last question. I hope it's sort of related. So a lot of our young people are using tetrahydrocannabinol, also known as weed, and some of them are using CBD oil or CBD products, edibles, and some are vaping. Can you just comment on that briefly and make your closing comments in that context as well?
The one thing we know is the marijuana that's out here now is not the marijuana that was prevalent when when we were younger. Now people are getting psychotic, they're getting addicted, and they're having all kinds of problems that I'm sure Dr. Lawson can elaborate on. But emergency room visits are going up, all related to this. So again, I think this is another cycle where our community is being uh, dumbed down, so to speak, for control.
And can you just comment on the difference in weed, tetrahydrocannabinol, and CBD, and is one better than the other?
Again, they're all different formats. Some are topical, some are added to food substances, and some are smoked. And they have all of these different genetic variations now. It would probably take a whole show
That's
to talk
discussing.
about.
Okay.
Yeah, I just want to note, and I'm surprised no one's complained about me yet, that I routinely go on some of the talk radio shows, especially in our community, because what's happened is that folks that's trying to promote CBD and some of these other agents come on these shows and and tell folks that they can cure almost everything. Or that they're wonderful for pain, they're wonderful for depression, they're wonderful for all kinds of things, which is unfortunately not the case. I did a major study a couple of decades ago showing that the rate of um, mental disorders increased in folks that use, and this has been replicated multiple times, that use marijuana related agents when they're in adolescence. And the idea that you can go out and take these agents and use them to bring wealth to the community by promoting marijuana farms just doesn't work because the other things are kept out. And the big problem is CBD in and of itself probably doesn't do much psychiatrically. It certainly doesn't, and it may help pain. It does help sedation. But there's little or no evidence that it really has persisting effects in terms of depression. And most importantly, a lot of these over-the-counter agents, folks sneak some THC in it to make it more desirable. And I've had several patients who just became frankly psychotic. And the underlying issue is that there's a certain gene that's, if you have it, there's a good chance you can get psychotic if you take THC. We don't do it routinely go out gene testing, so it's hard to predict who that may be. So the take-home message is if you like CBD and you find that it works, great, but make sure it's CBD and don't have other additives like THC in it to make it a little more desirable or make you feel a little bit better.
Well, I'd like to appreciate Dr. Lawson and also Dr. Chapman, especially for coming today. And Dr. Neighbor Stevens have some final comments, concluding comments.
Well, thank you. Thank you to our guests today. We are more than likely going to be having many more conversations like this as we proceed in this year. My closing comment, though, is to again urge our audience to get as much credible information as possible and use that information to influence your elected leaders, because that is one of the few ways we have of dealing with the state that we're in.
Thank you very much, Dr. Barbara Neighbor Stevens and our other co-moderators, and Dr. Chapman. I really want to thank you for your excellent presentation. I appreciate the honor that they've given you, and Dr. Lawson, as always, you're great. And in my final comments, I want to look forward, everybody, to 2026 and hoping that people vote the correct way. Now, a friend of mine that I spoke with, who's a neurologist in Washington, D.C., primarily at the Washington Hospital Center, gave me some interesting statistics. And he said that it is not the fact that Black men our black women voted for the current administration that had any effect. Basically, it works out to be 1% of the vote, whereas 70% of the vote is a white vote. So what happened with this election is that white females elected the current administration, and previously they had voted Democratic. So we can't say vote Democratic or Republican because we're a nonprofit, but we do have to get more people to see that they are harming communities of color if they don't vote more equitably. Thank you, everybody. Thank you, Simon. Have a great Sunday, everybody. Have a good day.
All right. Bye-bye.
Bye.